Good afternoon, everyone. We're going to give just a few seconds for people to get in, and then we'll get started. Okay, we're going to go ahead and get started. Good afternoon, and welcome to today's Recovery Summit session. This webinar is part of Recovery Summit series hosted each September by St. Clair County Community Mental Health in recognition of National Recovery Month. Just a few quick reminders. Today's session is being recorded and will be available on the SCC CMH YouTube channel. Please use the chat box for any questions or comments. Our presenter will address them as time allows. For those requesting continuing education credits, please be sure to remain on the webinar for the full session and complete will be emailed to you after. We're honored to be joined today by Dr. Elizabeth Hoffman from the University of Michigan. Dr. Hoffman is board certified in internal medicine, psychiatry, and addiction medicine. She splits her clinical time between hospital medicine, psychiatry consults, and addiction consults at Michigan Medicine. Welcome, Dr. Hoffman.
Thank you. Thanks so much for having me. So today I'll be talking to you all about substance use disorders in the elderly population. I have no relevant disclosures, financial or otherwise. My objectives for this talk are for you to understand and describe the scope of substance use disorders in the elderly, know when to screen, how to diagnose substance use disorders, know how to differentiate iatrogenic dependence from a use disorder, particularly when it comes to opioids. I hope that you'll learn more about how to treat some of the most common substance use disorders. And finally, I hope that we can develop some harm reduction strategies, make efforts to reduce stigma as well. So I'll start with the definition of addiction, which according to ASAM, or the American Society of Addiction Medicine, is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. So addiction can develop at any point during the lifespan. Older adults are generally underdiagnosed and undertreated as a population. However, they're just as likely, if not more likely, compared to younger individuals, to achieve stable recovery with appropriate identification and treatment. We know that there is a growing need for addiction care in the elderly by virtue of the fact that this population is growing as our rates are of substance use. The orange line represents U.S. Census data from 2020, showing that compared to the year 2000, as represented by the blue line, U.S. adults 65 and older are living longer and are making up approximately 18% of the U.S. population. So that's over 61 million people. Particularly the baby boomers, or folks born between 1946 and 64, do have higher rates of drug and alcohol use than previous generations. So this data comes from the 2021-2022 National Surveys on Drug Use and Health, looking specifically at adults 60 and older. In terms of past month cigarette use, 11.3% of women and 13.7% of men smoked in the past month. Over 10% of women and 15% of men binged alcohol, and a similar percentage of individuals used a non-prescribed substance, with marijuana being the most commonly used non-prescribed substance. Our numbers in Michigan are a little bit higher. Last year, Michigan had the highest per capita sales of legal cannabis in the US. From my perspective, it's also important to note that the study excluded residents of institutional group settings like nursing homes, long-term care hospitals, jails, mental health institutions, and unhoused individuals. So these numbers are likely underestimates. In 2022, about 1 in 11 older adults had a diagnosable substance use disorder in the past year, particularly alcohol use disorder. And there's certainly a major gap in care. So only about 30% of people 60 and older who require treatment are able to access and receive it. Women are less likely than men to receive treatment. Some of the barriers are due to stigma. Often providers are reluctant to screen or offer treatment because there's an assumption that older people might be more stuck in their ways or less likely to accept or benefit from treatment. Often there's a discomfort around the topic that gets mislabeled as respect for autonomy. Sometimes providers miss signs and symptoms of substance use instead, attributing them to the aging process, like falls or memory issues. And patients themselves may have difficulty with access due to cost, transportation, and challenges in navigating the healthcare system. So how does addiction develop? And what I want to highlight in particular is that when it comes to addiction, it is a disease process and not a moral or conscientious failure. For many people, the initial use of a substance is typically impulsive, and if the experience creates a positive feeling or euphoria or alleviates a negative feeling, well, that reinforces the use. And the environment and social circumstances also play a role here. Over time, regular repeated use can lead to the development of tolerance. Often people will increase the amount or frequency of use in order to attempt to achieve similar results as the initial or early effects. But over time, with the repeated stimulation and exogenous dopamine, the body's natural dopamine and receptors will fall or downregulate because of that expectation of that exogenous source or outside the body source. But when the individual doesn't give the body what it's used to, it creates a terrible feeling or state of withdrawal. So over time, use shifts from being impulsive to being compulsive. And really, this is the body's natural tendency towards homeostasis. The difference between dependence and addiction was really all in kind of how the individual is affected by and responds to this process. This picture, this table is a nice depiction of how dopamine is released in response to different substances, particularly stimulants, but then also nicotine and morphine. Again, over time, the body doesn't need to make and release as much dopamine on its own if it does have a continuous exogenous source. So I want to highlight that addiction is a relapsing and remitting chronic disease with rates of relapse similar to other chronic illnesses. So we really do need to shift our understanding in order to better care for our patients. Older adults may be more prone to developing substance use disorders due to loss of friends and family and community with resulting social isolation. The development of medical comorbidities like chronic pain, decreased mobility, sleep, and cognitive problems. And all of these issues exacerbate substance use and the negative outcomes that are associated with substance use. So recognizing substance use disorders in older adults carries unique challenges, but it's important to consider substance use in our differential when we see mood changes, disorientation, problems in decision making, an increase in falls, bruises, injuries, poor hygiene, poor nutrition, sleep problems, any kind of autonomic dysfunction. And then, of course, if there's any changes in use or tolerance or unusual responses to medications. This should really perk our ears as providers to go into screening mode. So I'm going to get to a case here. So this first case is about a 74-year-old retired school teacher with a history of depression who presents to you expressing a desire to reduce her alcohol intake. She reports drinking 4 to 5 glasses of wine a night to help relax and sleep. And she has always enjoyed wine, but her intake has increased since her husband passed away 6 months ago. So there's two questions I might ask myself. How concerned should I be about her drinking pattern? And what should I do for her? In terms of alcohol and what quantifies a standard drink, the US dietary guidelines recommend that generally healthy adult women do not exceed 1 drink a day, and men do not exceed 2 drinks a day. And essentially, they recommend to avoid alcohol otherwise in the case of anybody with an underlying medical condition. The NIA and SAMHSA recommend that any adult over the age of 65, regardless of gender, does not consume more than 1 standard drink per day. Nowadays the argument that red wine is okay and even healthy because of the antioxidants is just it's not there. The official statement is that there really is no safe amount of alcohol for older adults. Okay, however, we know that alcohol is the most used psychoactive substance among older adults. So even before COVID, alcohol misuse was on the rise and increased 107% between 2001 and 2013. In 2020, about 58% of older adults in the US drank some amount of alcohol. As I mentioned before, to some extent, this is related to the fact that the baby boomer generation had higher rates of substance use in their youth compared to prior generations, and are either carrying those habits forward or they're starting up again later in life. But rates of binge drinking and heavy drinking in older women in particular have been increasing. As I mentioned before, over 10% of women and over 15% of men over the age of 60 are binge drinking. Binge drinking is defined as at least 4 drinks for women or 5 drinks for men on one occasion. Again, this data is collected from civilian housed individuals and not folks who are homeless or institutionalized. So why is alcohol so much worse in older adults? The aging process, so changes in metabolism as well as a decrease in total body water volume, make older adults more vulnerable to the effects of alcohol. Older adults are more likely to be on medications that can interact with alcohol. As a side, 40% of older adults take 5 or more prescription medications per day. So that just increases the chances that there might be a medication that will interact with alcohol. A lot of older adults are prescribed benzodiazepines, sedative hypnotics, or anticholinergic medicines. And even without an increase in amount or frequency, older patients are more prone to becoming intoxicated and the adverse effects that go along with this, like dizziness and falls, cognitive issues, dehydration, and organ damage, and so on. But back to our patient, she's drinking up to 5 glasses or essentially a bottle of wine a night, multiple nights per week. We know enough here to be concerned about her drinking, but we want to get a little bit more information. So there's several validated screening tools that can help us better assess alcohol use disorder in older adults. Screening should really be done as part of our routine mental health and physical health care, and should be updated annually or when there are any kind of major life changes. The CAGE and the Audit C are both provider administered. The CAGE is a quick and dirty acronym to help identify someone with problematic drinking. Have you ever felt you needed to C, cut back on your drinking? Have you ever been A, annoyed by people criticizing your drinking? Has your drinking caused you to feel G, guilty? And have you ever needed an E, eye opener? The Audit C is just 3 questions asking about numbers, both amount and frequency of drinks, and not necessarily assessing how alcohol impacts a person's life. That is better evaluated by using the audit, which also has a self-report version that patients can complete. And there are a few others that are very reasonable to use. To save time, the Audit C or the NIAA single alcohol screening question are great. The single question screening asks, how many times in the past year have you had X or more drinks in a day? Where X is for men and where X is 5 for men and 4 for women, and a response of greater than or equal to 1 is considered positive. So then the audit is a nice follow-up to that and can be administered by the provider, or there's a self-screen form, like I mentioned. A score of 8 or more indicates hazardous or harmful alcohol use. The audit is nice. It's been validated across genders in a wide range of racial and ethnic groups, as well suited for primary care settings or outpatient mental health settings. If you're not a fan of lengthy screens or don't have time, I'll get to the kind of quick and dirty tool in a minute here. All right, so while we're on the subject of screening, I'll add that there are reliable and valid screening tools to assess substance use in general. And we really need to be thoughtful about how we're approaching these screens in patients. We need to be transparent about why we're screening, remind people that the information is confidential, and ideally, we're approaching this topic with compassion, empathy, and non-judgment. The subs is a nice overview that asks about frequency of substance use in the past year, specifically tobacco, alcohol, and any illegal drug, including marijuana. Remember, it's federally illegal, and use of prescription meds in a non-prescribed manner. It is important in older adults to ask about lifetime use. For example, 2/3 of older adults with alcohol use disorder had onset prior to the age of 50. So I'll often ask, when did you start drinking? At what point did alcohol become a problem for you? Have you had prolonged periods of abstinence? And how long and how did you achieve that? And what has your use looked like in the past year? Okay, so back to our case, you identify that your patient is drinking heavily. She doesn't use any other substances. Does she have alcohol use disorder? So in terms of making the diagnosis of alcohol use disorder, the gold standard is the DSM. All right, so here are the criteria. We need at least 2 of the following within a 12-month period. The criteria that many people with alcohol use disorder will meet is using alcohol in larger amounts or over a longer period of time than was intended. Of course, you have factors of alcohol, of tolerance and withdrawal that point to concerning use. But the hallmark of a use disorder is really how alcohol impacts one's functioning. I do want to quickly point out here too that the DSM criteria for a use disorder are the same across all substances. We'll see that later. So with that, we use the 4 C's as a helpful mnemonic to diagnose addiction: compulsion, craving, consequences, and control. So I might ask, are you, compelled to drink alcohol despite knowing the downsides? Do you have irresistible urges and cravings that may be psychological or physiological? Have there been negative consequences related to your use? Has your use affected your relationships, your job, finances? Have you had issues with the law? Have you had difficulty controlling your use despite attempts or desire to stop? So again, we're really concerned more about how has your use affected your life and your ability to function. So there are definitely several challenges to using the DSM criteria in the geriatric population. People may not have major obligations outside the home any longer. They might be retired. Instead, we might ask about ability to complete tasks like shopping or bill pay. Their social circles may be far more limited, so obtaining collateral from a friend or family member can be helpful if that's available to you. And then asking about frequent falls, injuries, bruising, in terms of as a substitute for necessarily physically hazardous situations. People may or may not be driving any longer. Okay, so case 1 continued. So the patient reports that she's been drinking more than desired, particularly since her husband died, to help manage stress and sadness. She has tried to cut back without success. She denies blackouts, morning drinking, or withdrawal symptoms. She reports no falls, health-related consequences, or legal issues related to alcohol. She's concerned that alcohol may be affecting her memory and contributing to poor sleep quality. She lives alone. She doesn't have, she denies other use of substances and has never been to substance use treatment. Her stated goal is to decrease her use. So because she has been drinking more than intended and has tried to cut back without success, she does meet criteria for mild alcohol use disorder. In terms of testing for alcohol use and sort of the health impacts, the blood alcohol concentration provides a real-time blood level. The ethyl glucuronide is a good urine test to test for alcohol use within the past 3 days. So if you're able to obtain that, it can be very helpful. And then, of course, just liver enzymes, blood counts, nutritional deficiencies that might go along with alcohol use disorder. Those can be very helpful tests to determine the impact. Just a quick plug or piece on the PEth. This is a great test that we often use to trend alcohol use over time in the outpatient setting. It can detect the presence of alcohol for up to 4 weeks after last use, and a result over 200 indicates heavy use. And it's you can trend it over time. There's no age or gender differences. Sometimes you do get a false positive if the patient has had blood transfusions, but other than that, I sort of liken it to the A1C of alcohol. All right, so you identify that your patient has mild alcohol use disorder. You provide brief intervention, counseling, and education, and refer to outpatient treatment with a plan to return in 2 weeks. She asks about medications to help decrease her alcohol use. So there are 3 FDA-approved medications for alcohol use disorder. Unfortunately, there is a lack of evidence when it comes to efficacy in the treatment of older adults. Disulfiram or Antabuse does cause acute sensitivity to alcohol by inhibiting aldehyde dehydrogenase, but its effects can be very harmful to older adults. So when alcohol is ingested, somebody who's taking disulfiram, it will cause the patient to feel effects similar to a hangover, and it's supposed to deter the patient from drinking. So these effects can really put a lot of stress on the cardiovascular system, can cause hypotension, arrhythmias, so it can be really risky for older people. It's also a medication that really needs to be closely monitored and is not ideal for people with cognitive issues. So it's not something I would gravitate to first. Acamprosate is known to reduce cravings for alcohol, but to date, there's no randomized controlled trials on the efficacy or safety of acamprosate with older adults. Likely because it can't be used really in individuals with renal impairment. So the best data we have is for naltrexone. It is important to note that naltrexone is metabolized through the liver, has to be used in caution with patients with impaired liver function. It's also an opioid blocker. Therefore, it cannot be used in patients who are taking opioids because it can prevent withdrawal symptoms. All right, so the patient does not present to her scheduled follow-up appointment with you. She represents 4 months later, stating that her alcohol use has increased. She did not follow up with outpatient resources. She's continued to drink a bottle of wine nightly, has added 2 to 3 shots of vodka per day. And she reports that her relationship with her daughter is strained because of her drinking. So clearly her alcohol use and its impacts on her life have worsened here. And in clinic this afternoon, she's mildly tremulous. She has a heart rate of 106. Her blood pressure is elevated. Her last drink was early this morning. So I'm going to kind of breeze through this in the interest of time, but essentially alcohol will stimulate the GABA receptors, and with chronic alcohol exposure, the brain will upregulate the excitatory NMDA or glutamate receptors and downregulate the inhibitory GABA receptors. So in the absence of alcohol during withdrawal, you have overabundance of glutamate, which is excitatory, and a lack of GABA, which is inhibitory. And so this leads to hyperexcitation, anxiety, seizures, blood pressure, and heart rate abnormalities. We want to treat alcohol withdrawal early in order to avoid progression to delirium, seizures, DTs. The amount used, the chronicity, and time since last drink are all super important factors in how alcohol withdrawal manifests. All right, so when to refer to the ER, anybody over the age of 65 is automatically out of that, minimal risk category. But anybody certainly who's had a history of complicated or severe withdrawal within the past year, anyone with active psychiatric symptoms, psychosis, severe depression, or suicidal ideation, anybody with active medical conditions, unstable, arrhythmias, heart disease, severe COPD. Certainly, if people are falling at home, if they're not really eating and drinking well, if they're really deconditioned, that would prompt me to send somebody to the ER. Especially if they don't have any kind of caregiver support, their living situation is unstable, they don't have access to transportation or technology for subsequent visits. If there's any kind of physiologic dependence on other substances like benzodiazepines or opioids. And then there's a couple kind of tools here, the pause or the CWA. Certainly if pause is 4 or greater, the CWA greater than 14, I will say outright, that doesn't have there's not a lot of data to support that number, in particular in the elderly. That's sort of like my rule of thumb, but again, it just completely, I would have a low index of concern to send somebody. And again, age over 65 automatically takes you out of that minimal risk category. I'm adding the CWA scale here for your review because a lot of people utilize this in clinical care settings. But again, if there's any neurologic findings, any visual or tactile disturbances, disorientation, significant restlessness or agitation, I would certainly be sending them to the emergency department for further evaluation. Older adults with alcohol use disorder are at higher risk for severe alcohol withdrawal syndrome. The PAUSE or Prediction of Alcohol Withdrawal Severity Scale is a very helpful tool to determine if the individual is at risk for severe alcohol withdrawal syndrome and in need of medically assisted treatment or referral to the ED. So I'll say, like, from an inpatient perspective, we often recommend that people who show up in the emergency department, that the ER doesn't discharge them if they have a pause greater than 4 or greater. It's really not something that should be managed outpatient. So these are just some potential options for outpatient treatment of alcohol withdrawal. It's important to remember that we're really targeting lower doses than in younger individuals and really a short course. We want to avoid a symptom-triggered approach in older adults and really ensure that this is only done if the patient has, you know, somebody at home with them that can supervise them. But really, gabapentin, Librium, Valium, low doses just for a couple days if, they have mild withdrawal symptoms. I would not use phenobarbital in the elderly. We do use it in younger people, but certainly its metabolism is a little unpredictable. It also has it's hepatically metabolized and can lead to sedation and falls. So I would be very cautious with that. Probably avoid it in older people. So when we're working with patients, it's really important to gauge their individual goals, utilize motivational interviewing to assess their readiness for change, provide education in a straightforward, non-judgmental fashion. As I previously mentioned, there's several unique challenges when treating older adults with substance use disorders. Some older adults find it really difficult to recognize or acknowledge that they might have a problem. We as providers can provide teaching about changes in metabolism with aging, the interactions between alcohol and specific medications, especially sedatives, the potential for falls, the relationship between alcohol and some medical problems like hypertension, liver issues, cognitive decline. We can provide the results of lab tests that detect levels of alcohol use and compare those results to the general population to help motivate patients to consider treatment. In terms of treatment options, our goal should really be to consider the least intensive option that best fits the individual needs, then increase the level of intensity if needed. So the least restrictive treatment option is early intervention, which is that education piece, followed by outpatient services, intensive outpatient, partial hospitalization, and then residential services. Of course, all of these treatment options are voluntary and each facility has its own requirements. So it's important to note that in order to attend these more intensive treatment options, generally patients have to be fully ambulatory and very independent in their functioning. And of course, certain insurance plans will not cover inpatient or residential substance use treatment. So that's something to be unfortunately mindful of. So I've just added some options for group recovery. Not everyone aligns with AA, but SMART recovery, Dharma recovery, or more sort of CBT and mindfulness-based support groups, respectively, that some people really enjoy. Okay. So I'm going to save questions till the end and switch gears here a little bit. So this is case number 2, a 66-year-old woman with long history of anxiety and diazepam and chronic back pain on oxycodone presents for follow-up. She's been on benzodiazepines and opioids for over 20 years and has been hesitant to come off. You are concerned for addiction. All right, so why do we need to be concerned about opioids? Because as you're well aware, we have an epidemic in this country. And as our patients are aging and living longer, becoming more susceptible to the effects of substances, they're more likely to suffer negative outcomes, including respiratory depression and death. Overdose death rates involving prescription opioids have declined, although still remain relatively high, particularly if prescription opioids are combined with alcohol or benzodiazepines or sedative hypnotic medications. And when I say that, I mean things like Ambien, which is quite common. So in particular, we worry about the rise in overdose death rates attributed primarily to fentanyl, which is approximately 100 times more potent than morphine and 50 times more potent than heroin. It's incredibly important to educate our patients, particularly those who are buying on the street or using non-prescribed pills, that a lethal dose of fentanyl is present in over 50% of pressed pills, including things that are sold as Adderall or Xanax. What's not shown here is the fourth wave of overdose deaths, which is really started in 2015, associated with the rise in fentanyl combined with stimulants. Okay, so we know that people over the age of 50 with OUD have an increased all-cause mortality rate compared with younger adults. It's an undertreated age group, but again, very high chances of recovery, and older adults tend to be more adherent to treatment. There are specific risks associated with opioid use, like coordination impairment, falls, fractures, constipation, respiratory depression, and that all of those risks are magnified if we're adding alcohol, benzodiazepine, sedative hypnotics. The opioid overdose death rate among older adults tripled between 2002 and 2021, disproportionately affecting minority populations. So this is important and something that I address on an inpatient setting frequently. Very often we see opioid dependence misdiagnosed as opioid use disorder, which, as you can imagine, can be very stigmatizing for patients and make it challenging for folks to access appropriate treatment and medications or lead to inappropriate care. So just because a patient is on chronic opioids does not mean that they have an opioid use disorder. Again, we have to make the diagnosis utilizing the DSM-5 criteria. And again, this criteria is the same as the criteria for alcohol use disorder. However, the criteria of tolerance and withdrawal do not apply when someone is prescribed opioids, as they are pharmacologic effects that are intrinsic to the opioids themselves. And that is a super, super important point. I will have very frequently providers, physicians will reach out saying, hey, I think this person has opioid use disorder because they're running out of their medications early. And they seem to have developed some tolerance to the medication. And I'm like, that's one piece of it, but that's not the whole story. And that in and of itself does not make a diagnosis of OUD. So again, the 4Cs are a helpful mnemonic to diagnose opioid use disorder. It's really important to assess the individual's belief about the substance, how they interact with the substance, how that substance impacts his or her life. I will say that some people, notably people who have used heroin or fentanyl, or purchased any street opioids, probably have had a diagnosis of OUD at some point. Okay. So this patient is counseled about the risks of opioids and offered buprenorphine, which is a medication that is FDA approved for both pain and opioid use disorder. It can be prescribed by any provider for either indication. It's a partial opioid agonist and it has a decreased risk for respiratory depression. I will also mention that it is a wonderful medication to treat opioid-induced hypersensitivity or pain that essentially gets worse as the person is on opioids for a longer and longer period of time. Often over time, people become sensitized to pain, and their pain is much more. It's like the more opioids they take, the worse their pain is essentially. And so the buprenorphine can kind of help eliminate that, which is one of the wonderful uses of it. But it is outside the scope of this talk to get into specifics about the buprenorphine dosing. But I will say that older people tolerate buprenorphine less well than younger people and often require lower doses. But anecdotally, the recommended dosages on the package insert tend to be inadequate for management of pain relief in patients who have been on chronic full agonist opioids. So I highly recommend going to Michigan Open. You can request a consultation with a provider who has experience in prescribing buprenorphine for both pain and OUD. So this is a wonderful resource to have that anybody can just kind of reach out and say, hey, I have a specific patient scenario and I need guidance on what to do. And they can give you direct feedback and advice. All right, so I do want to talk briefly again about benzodiazepines. Unfortunately, benzodiazepines and barbiturates are the most commonly prescribed medications for the treatment of insomnia in older adults. Even though we know that these medications do not induce good quality sleep, benzodiazepines carry the risk of issues with balance, falls, cognitive decline, worsening sleep quality with long-term use, and does have addiction potential. So we always recommend, um, avoiding any kind of co-prescribing, educating patients on the risks of combined treatment, a gradual outpatient taper. It does need to be done slowly over time, particularly the longer somebody has been on the medication. And again, the assessment for benzodiazepine use disorder really follows the same DSM criteria as for AUD and OUD. Again, I will point out though that the tolerance and withdrawal pieces are because those factors are intrinsic to the medication. I wouldn't necessarily utilize those criteria on their own for the diagnosis. Okay, so case number 3, a 68-year-old man with a history of schizophrenia, opioid use disorder, prior use of heroin, and stimulant use disorder with cocaine presents for care. He has been prescribed Suboxone 24 milligrams a day for about 6 years, which was previously managed by addiction medicine and then transferred to primary care. However, the patient's PCP just retired. He is out of his medication. He's been to multiple inpatient and outpatient treatment facilities and programs in the past, and he did have an opioid overdose 1 year ago. He's had multiple ED visits over the past few months for various complaints like chest pain, trauma from falls. During a recent ED visit, he had a positive tox screen for fentanyl and cocaine. The tox screen did not test for buprenorphine. Okay, so what should I do next? I'm just going to kind of click through all of these so I don't get a little lost. Okay. So we want to make sure he's taking the buprenorphine. I mean, of course, I often ask patients, when was the last time you took the buprenorphine? And then we can verify, that he's taking it with testing. It's important to be mindful that at the University of Michigan, only certain drug screens and confirmatory tests include buprenorphine. So like here we have a buprenorphine and metabolites test that not only tests for the presence of bup, but also tests for the active metabolite, which helps to ensure that the medication is in someone's system. So I have had circumstances where, the urine screen will be positive for buprenorphine, but not the metabolite, which tells me that it wasn't taken, but it was probably dropped in the sample. So that's, just kind of one thing, but it is also important to ask about recent substance use and test for other substances, not as a punitive measure, but as a way of providing information about what is in the drug supply. So, for example, this gentleman who had fentanyl in his system, it's very possible he did not even intend to take fentanyl. It's possible that it was an adulterant in the cocaine that he was taking, or vice versa, right? So it's definitely provides information to patients. And then, often there might be things like xylazine, and these can have unintended adverse effects. So it's important to note also that many drug screens will test for opiates, but not synthetic opioids like fentanyl. So that is something that is important to know. So really knowing kind of what do you have access to in terms of testing, and then what do those certain tests, what are they looking for specifically? What are they looking at? We really do want to verify that the patient knows how to take the Suboxone correctly. So there's various formulations. The one that is most often covered by insurance is the film. And we want to, verify correct technique. So the film, we always counsel patients to, get their mouths a little bit wet, have a drink of water, put the film under the tongue, and don't talk or smoke or eat or drink for at least 20 minutes as the Suboxone is fully dissolving, because that is how the medication enters the bloodstream. It's through the blood vessels underneath the tongue. It does not get absorbed if it's swallowed. And just as a reminder, the naloxone that is in Suboxone is really just a safety mechanism that's not absorbed when the medication is taken correctly. It's only there if the patient were to melt it down and inject it. So people will say, oh, I can't take Suboxone because the naloxone puts me into withdrawal. That's not true. That is the buprenorphine that actually does that, not the naloxone. And then, of course, the other thing to know, right, is if patients have been taking fentanyl, fentanyl is incredibly lipophilic, and meaning it hangs around in the fat and lingers for several days to a week or more. So this makes Suboxone inductions very, very challenging. I'll say that recently we had a patient who came into the emergency department in withdrawal. He had last used fentanyl 3 days prior to presentation and wanted to get back on his Suboxone, so he took 16 milligrams that morning and unfortunately precipitated himself. Ultimately, we gave him more Suboxone, which, was the answer. And that was really because he didn't have another indication for hospital admission. Most often we use a micro-initiation technique, providing very small doses of buprenorphine while the patient's continuing full agonist opioids. So a lot of these induction techniques will vary, but it's not like it was in the days of fentanyl. It does take some, you do have to know what you're doing, and that's where M-Open can also be very helpful. Okay, so just some considerations with regard to this case again. Is he taking the buprenorphine? We have to have some tox screen, especially in the outpatient setting. If you're a provider who's going to be who's going to be prescribing this on an ongoing basis, it is helpful to have regular tox screens to ensure that the patient is taking it. Again, the cocaine supply is heavily adulterated with fentanyl. Does the patient even know he tested positive for fentanyl? And that really, if anybody has a history of overdose, we really want to be targeting at least 16 milligrams a day of buprenorphine or Suboxone, and that is protective against overdose. And insurance nowadays will cover actually up to 32 milligrams per day, which has been very helpful for some of our patients with very severe opioid use disorder who just don't really respond well to the 24 milligrams a day. It's also important that to recognize that buprenorphine will treat cravings for opioids, but not stimulants. All right. So we want to be mindful of symptoms of opioid withdrawal. So typically, while it's not considered to be deadly in younger people, older people with underlying end organ disease can have adverse effects and adverse events, particularly cardiovascular collapse, arrhythmias if there's poorly treated opioid withdrawal. So again, I would have a low threshold to refer to the emergency department if there are any significant findings, particularly autonomic dysfunction. We typically utilize the COWS when diagnosing opioid withdrawal. It is important to note that COWS is largely objective and doesn't include cravings, which is a significant driver of return to use. So I will often ask patients about their cravings. Remember that in the outpatient setting, we're not able to prescribe full agonist opioids for patients who are in opioid withdrawal. That is a federal law. Unless they're admitted to the hospital, that's really the only time that we can use full agonist opioids, and we do. The two primary treatments that we lean on for opioid withdrawal, in addition to full agonist opioids on the inpatient side, are Suboxone versus methadone, and then symptom management. These are some adjunct treatments: clonidine, Zofran or Danzatron, trazodone, NSAIDs, and ibuprofen, hydroxyzine, just things that we can also prescribe to patients in the outpatient setting to help manage their symptoms. So there's 3 FDA-approved treatments in adults. So buprenorphine is that partial agonist, methadone is a full agonist, and naltrexone is an antagonist. And I'll kind of get into more detail about these. So buprenorphine is our, I would say, preferred medication, particularly in older adults. It can be prescribed by anybody for pain or opioid use disorder. Certainly when the indication is pain, the dosing structure and strategy is quite different. I also want to mention that buprenorphine will show up on maps. So we can follow the fill history. Methadone, on the other hand, is not a medication that is prescribed, but rather it has to be dispensed by a SAMHSA certified OTP, most often daily, but obviously, that a lot of people qualify for take homes, and some of the policies and procedures around that are changing, making it trying to increase access to methadone. It is hepatically metabolized and patients, I think, who are older can certainly have unintended side effects. And we do need to be cautious, I think, of kind of checking in on patients and seeing like, hey, the dose that was working for you for many years, now that you're getting older, can we start coming down on this a little bit? Even if you don't work at a methadone clinic, you can still kind of talk to the patient about how they're doing with that medication. And then naltrexone is not a medication that I typically recommend for folks with OUD, and really because it does not treat cravings or urges. It really will rapidly lower somebody's opioid tolerance, and therefore, if they return to use, can increase their risk of overdose and death. Okay, again, we want to ensure we're offering a variety of treatment options ranging from outpatient to inpatient, while being mindful that a lot of our inpatient facilities might not accept patients on methadone. Some sober living environments may only accept specific formulations of buprenorphine, like the long-acting injectable form. So it is helpful to know kind of what are the options within your area and what will they accept. Just a note on stimulants and cocaine. So there's really no FDA-approved medication for the treatment of stimulant use disorder. Behavioral therapy interventions are first line. I really wish that we had access to contingency management, which unfortunately isn't something we have here in our area. Maybe where you all are, there is access, but essentially there's a lot of really great data to support contingency management for stimulant use disorder, whereby essentially people come in a couple times a week and they provide a urine sample, and if it's negative for stimulants, then they get money or a gift card. And so essentially the more negative drug screens they have for stimulants, then the more money they make. And that has been very, very effective for people. So as I mentioned earlier, cannabis use has risen among older adults, and in Michigan, where recreational cannabis is legal, it's quite common to see patients positive for cannabis. There's no FDA-approved medications for the treatment of cannabis use disorder. There is some promising results for NAC, but it has not been studied in older adults. I think the most important thing that we can do is really provide education to our patients about the harmful effects of cannabis, particularly if it's combined with benzodiazepines or alcohol, but on its own can, worsen memory impairment, increase risk of injury, cause anxiety and depression. And all of those risks will increase with age. All right, so we're kind of wrapping up. I just want to talk about the importance of discussing harm reduction strategies in real time. So I think particularly for anybody who has a risk of unintended or is at risk of fentanyl exposure and respiratory depression and opioid withdrawal, we want to make sure that we're providing Narcan. I know that here at the hospital now we have Narcan available for free in vending machines near the emergency department, in the cafeteria. So having those available to people, I see them on the streets in Ann Arbor. So that has been, I think, wonderful. And then also for people who are not intending to use fentanyl, to provide them access to fentanyl test strips. There's also xylazine test strips that are available as well. And then, really educating people about and asking people about, do they use IV? What kind of water source do you use? I'll often tell people, if it's great that you use bottled water, make sure you don't drink from the bottle before you use it. Don't use tap water. If you're going to use tap water, boil it and let it cool before you do that. Clean your skin beforehand. I've had a lot of patients tell me they clean it afterwards, using sterile needles, not reusing needles and things like that. This website can kind of bring you to some additional resources. And then we do offer buprenorphine to anybody who's had, especially a recent history of unintended overdose. All right, so asking all older adults about their use of alcohol, their use of substances, is an accepted and expected thing in clinical practice. Remember that people may require some accommodations for hearing impairment, vision impairment. Beware that the DSM criteria may not apply to older adults who are retired or more socially isolated, but it is important to ask about episodes of confusion, functional status, risk of falls, obtain collateral if that's available to you. Try not to allow the discomfort of talking about this with with a patient that might be older than you, who sometimes people can be deferential. There's fear of being disrespectful. If we can just kind of approach this in a matter-of-fact, non-judgmental sort of place of concern and care, that's, I think, typically the best way. We want to make sure we're reaching for screening tools that have been, validated in our older populations. Certainly avoid polypharmacy. There's so much. Consider the whole person. There's no wrong door. So we want to also start with the problem of greatest concern to the patient, asking what their goals are in terms of their substance use, have, solutions and be able to provide them with support at every follow-up appointment, and then also avoid stigmatizing language. Let's remember that stigma can come from within. It can come from the medical community. It comes from the general community at large. There is a huge amount of stigma that comes from, medical providers in particular. And so just really being aware of the language that we use in particular, in our notes and in our conversations, not saying things like abuse, drug abuse, substance abuse, clean, dirty, addict, kind of all of these phrases and terms just serve to, worsen that stigma and worsen, I think, the care that patients receive. We want to make sure we're providing very good, high quality care. These are some resources. And that is all I have. If there are any questions, I'm happy to take any, but if not, that's fine too.
There's currently no questions. I was just giving it a second to see if we get any that pop up here.
Go blue.
So it's looking like just a lot of thank yous and great, great information. Just give it a couple more seconds. All right. It doesn't look like we're having any questions, just a lot of thank yous. We really appreciate you coming in today, Dr. Hoffman, and sharing your time and information with us. Very useful information. I also want to thank everyone who joined the session. We hope the information was both valuable and useful for all of you. Today's presentation is just one of many webinars being offered throughout September as part of our Recovery Summit. For details and registration for upcoming sessions, please visit our website at www.sccmh.org under the Events tab. And also keep an eye out for a short survey in your email. Your input is vital in helping us continue to improve and shape future events. For those requesting MCBAP and peer certificates, they will be emailed out in mid-October. If you're requesting Social Work CEs, your certificate will be emailed to you after payment is received if applicable. Thanks again for joining us today. We look forward to seeing you all next time. And thank you again, Dr. Huffman. Hope you all have a
Thank you,
great
everyone.
day.
You too. Take care.